Well, gang, welcome back. Hope your Easter was stellar. Hope you enjoyed this weather. We had yesterday, I saw a lot of people out worshiping the sun. S-U-N, not S-O-N. Yesterday, and well, it should be after days of overcast. It was nice to see that bright glowing star up there. And I'm from California, as you guys know. I was raised in the San Joaquin Valley, which is frankly a desert environment. So sometimes I just walk outside and go, it's just so good to feel that nice, effulgent warmth all over your body. It's like the earth is waking up again. The leaf buds are coming out on the trees, and the dandelions are poking their heads out on the lawn. Those bloody things. So hey, there's but hey, I'll take the heat with the dandelions. Dandelions, you can pull them up. Snow, yeah, that's another story. So we are going to continue our discussion of angina pectoris. That will lead us to a discussion of heart failure, and then we'll go from there into blood clotting, because we'll see the treatment very often of angina will include drugs to prevent the blood from clotting. So we'll review the vessels that feed the heart, then we'll look at what happens when those vessels get plugged. Okay, let's start with a word of prayer. Father, thank you for a gorgeous day. Thank you for a gorgeous day yesterday. We pray for those who are on quarantine, those who are sick. Thank you. Some of our compatriots are back after being sick. For those on quarantine, Lord, please help them to deal with the loneliness that can be part of that. Thank you that the university is trying very hard to get services to them, but the stultifying loneliness, Lord, can really be terrible. We are social creatures made for fellowship, not just with you, but with each other. We pray now that we would remember those in quarantine, that we would tend to them, not just with prayer, but with emails, phone calls, cards, whatever. Thank you for this time. Help us to remember what we learned a week ago. In Jesus' name, amen. And everyone have find the quiz and do the quiz, and okay. Let me just take a little straw poll. I know there some people asked me if we could do all our quizzes on Blackboard. Who would like that idea to have all our quizzes on Blackboard? We see hands. That's all of you. Okay. Those opposed? Okay, so we'll do our quizzes now. From now on Blackboard. They will be done sometime on Friday, and then they'll be due end of the day on Mondays. You'll have the weekend to do them. And if you have sports events, things like that on Saturday, I would hope that Sunday would be a day to be able to do the quiz. If you then have games on Monday, I'll see what I could do about working around that. Okay, vessels of the heart. Remember, we have the two main arteries, and you can see them here. They essentially extend from the sinus of Valsalva, coming from the base of the aorta. So you have a leftward branch, left coronary artery. You have a rightward branch, right coronary artery. The leftward branch is going to swing around the side here. It will sit in that little sulcus between the atrium and the ventricle that you can see here. Keep in mind the veins and the arteries of the heart are on the surface of the heart. They have extensions that then dive into the myocardium and the endocardium, but the vessels are all on the surface. That's important to remember. And I have a picture that'll kind of show you how the branching of those vessels feeds the actual myocardium. That means if you're going to get blood to the myocardium, you have to have a vessel on the surface that's open for it to happen. And when we consider some of the reasons why the heart does it this way, there's a good reason why it does it this way. All right, so we have that point of division between the atrium and the ventricles, the atrioventricular groove, atrioventricular sulcus. That left coronary artery swings around, becomes a circumflex artery. And you can see that right here. So here's our circumflex right there. There's a branch that's going to descend down this way. That's going to be the LAD, left anterior descending artery. Right there, that's a biggie. A lot of your heart attacks will involve the LAD. In fact, you have a blockage high up on the LAD. You know what they call that in cardiology parlance? They call that the widowmaker. You can guess why it's called the widowmaker. Yeah, the widowmaker up there. All right, so the left anterior descending artery, and this will travel down the anterior interventricular sulcus or the anterior interventricular groove. That LAD will supply 2/3 of the interventricular septum. It will supply the anterolateral papillary muscle and the anterior surface of the left ventricle. So if this is a left ventricle here, all that is essentially supplied by the LAD. So that second branch, it swings around here, the circumflex, that's going to go around the left side of the heart. It'll supply the left atrium, and the posterior walls of the ventricle. So the LAD does the front wall of the left ventricle, circumflex does the back wall of the left ventricle. Then over here, we have the right coronary artery, right there. And the right coronary artery also originates from the sinus of Valsalva. It heads in the opposite direction from the left coronary artery. Big surprise there. Well, no surprise there. It's going to supply the right ventricular outflow tract. It'll supply the SA node and the right atrium. The right ventricular outflow tract, the sinoatrial node most of the time, and the right atrium. So it has a few branches. The major branches down here, unfortunately, it's not labeled. This is called the right marginal artery. And I think the next picture, yep, has it right here. The right marginal branch, right marginal artery. It's this pup right here. See that? Right marginal branch. The right marginal branch will supply the right ventricular muscle. Katya? So if you have a quadruple bypass, you may have blockages in both of these arteries here, and you have to do a bypass essentially that goes above this one and then below that one. So it'll take blood from here, switch it to there. Then you have to usually have another one that goes from above the blockage here to down over there. So you get blood essentially going from here to here to here to here. So you have two different coronary artery bypass grafts that you have to do. That type of surgery, it's done very routinely nowadays. It's the bread and butter of a lot of your cardiothoracic surgeons, but you have to essentially take a vein from someplace else, usually from the leg, and fashion it into a place where it wasn't designed to be. And then hopefully it takes and adapts. Occasionally, those grafts don't take. Usually nowadays they take because the surgery has gotten much better. Usually they take. So you take usually a branch from the saphenous vein, usually, and then just kind of plop it right down on the surface of the heart and plug it in. And sometimes they work, other times they get clogged really fast too. So that's the other issue. Okay, there's your right marginal, and then let's see, swing around here like this. And your grooves on the back surface of the heart, your right coronary artery that you can see here is going to branch into the posterior descending artery. Posterior descending artery, that'd be this up here. And then also the posterior lateral ventricular branch, or this, which would be this here. That's a posterior lateral ventricular, also known as the PLV. So the posterior descending artery with the posterior lateral ventricular, they're going to supply the atrioventricular node. They'll supply 2/3 of the inferior lateral walls of the left ventricle, and also the posterior medial papillary muscle. I'll say that again, the AV node, 2/3 of the inferior lateral walls of the left ventricle. As you can see here, this one's going to get just this little piece here of the left ventricle. And then the posterior medial papillary muscle. Coronary arteries can vary. So sometimes your posterior lateral, like you see here, is actually supplied by the circumflex. And other times here, the PDA is also supplied by the circumflex. If you have that variant, you have a so-called left dominant heart circulation. Left dominant heart circulation. The most common is a right dominant heart circulation, like you see here. Some people, the right and the left coronary arteries contribute to these vessels. And that is very uncommon. That's called codominant circulation. Codominant circulation. What about the veins? The veins just follow the arteries, pretty much. And so you have this vein here, which gets called the great cardiac vein. The great cardiac vein. So the great cardiac vein is this one right here. That's the great cardiac vein. Then you have the middle cardiac vein, which would be this one here. Notice it just follows in a lot of ways the right coronary artery. So the middle cardiac vein, and then you have a vein that swings around here. That is called the small cardiac vein. So you have great, middle, and small cardiac veins. These are going to empty into the so-called cardiac sinus. And the cardiac sinus will empty into the right ventricle. All right, so what happens if those vessels get plugged by atherosclerotic lesions? So if you get blockage in about 70% of the vessel, you will start to get chest pain, particularly when you are either exposed to the cold or you do strenuous, after you do very strenuous sorts of exercise or activity of some sort. Or under conditions of very great emotional stress or something like that. That pain tends to be substernal. So it's so-called retrosternal chest discomfort. Retrosternal chest discomfort. Let me use my makeshift blackboard here. Oh, it's not working here. Let's try this again. Okay, come on, screen. Yes, discard. All right, let's try this again. There we go. Okay, so you get retrosternal chest pain, or retrosternal chest discomfort. This could be described sometimes as a pressure or a heaviness or a squeezing of the chest. So some people will say, feels like an elephant sitting on their chest. Others will say, feels kind of like chest is being squeezed. Some will describe it as a heaviness on their chest. Others will describe it as a burning sensation, burning or choking sensation. The pain can stay on the chest or it can radiate. So if it radiates, it'll tend to radiate either to the back, usually between the shoulder blades, or the jaw, or the shoulders. And if it radiates to the shoulders, usually radiates to the left shoulder. And again, it's precipitated by exposure to cold, to emotional stress, or to physical exertion. It lasts usually about 3 to 5 minutes. And it's relieved by rest or by nitroglycerin. And the pain intensity doesn't change if you lie down, sit down, what have you. It's the rest part. That's the biggie. Now, if you hook an EKG up to somebody having a angina pectoris attack, what you will see is ST interval depression. ST interval depression. Let me emphasize here. In a heart attack, cardiomyocytes die because of ischemia. During angina, cardiomyocytes do not die. They do not die. But they're essentially complaining and telling you, if you don't rest, we're going to die. What causes the pain? The thing that seems to cause the pain is that ATP gets broken down to adenosine. Adenosine is a signaler in the cardiac muscle, and that seems to be responsible for the pain. It's not the only thing responsible for the pain, but it seems to be the main signaler involved in pain. Incidentally, the term angina comes from the Latin angere. Angere means to strangle. To strangle. That's angina. Now, my next slide would show a myocardial infarction or a heart attack. Now, with a heart attack, which is called a myocardial infarction, with a learn how to spell. With a myocardial infarction, you get death of cardiomyocytes. I'm just going to say CM, cardiomyocytes. Therefore, one of the best markers in the blood for death of cardiomyocytes is cardiac troponin. You see this in blood, your patient's had a heart attack. Furthermore, this will last in the blood for many hours. With angina, you will not see troponin in the blood. With a heart attack, you will. Also, with a heart attack, the pain is not relieved by rest or nitroglycerin. That's an important distinguisher between angina and a heart attack. Also, with a heart attack, what do you see in the EKG with a heart attack? Do you see ST depression? No. What do you see, Jacob? You see ST elevation. You may not, but you may see arrhythmias. Dead cardiomyocytes, their mitochondria start to die, and the mitochondria release enormous amounts of calcium. So that can cause, in fact, that sometimes that's what actually causes the sudden cardiac death or the arrhythmias. And that's why with heart attack patients, you need to give them this drug called amiodarone to make sure you quell those arrhythmias. So you see ST elevation. Oh, and who asked that question, by the way? Oh, Katya, if you have a massive heart attack, you'll actually bradycardia. Sometimes the heart will respond, yeah, by beating faster. Also, the sympathetic nervous system takes over and the patient gets flushed and they sweat and the heart will start to beat fast. But it's a massive heart attack. The heart can't beat fast because so much of the heart is dying. So that can fool you. Be careful with that. That can fool you. All right, pause, questions. Very good. Let's go back to our slides then. Now, this pain is not like, oh, I did too many declines in the gym. Oh man, that hurts. No, this pain is I've got to grab onto something. It hurts. In fact, there's something, Levine sign. The Levine sign is you clench the fist and you put it over the chest and you double over like this. That when you see a Levine sign like that, that's a good sign of either a heart attack or angina. Some people don't do, they do the palm, so it's called the palm sign. But if you put the hand over the heart and you double over, that's a good sign that someone's having either angina or a heart attack, because it hurts. That's why heart attack patients, the pain often increases sympathetic activation, so usually give them morphine. So the signs of a heart attack are similar, but with a heart attack, again, the cardiomyocytes are dying. Now, heart attacks come in two flavors. There's STEMI and NSTEMI, ST elevated myocardial infarction, non-ST elevated myocardial infarction. The difference is that the non-elevated myocardial infarctions, the death of the cardiomyocytes does not extend throughout the entire wall of the myocardium. It's just mainly in the endocardium and part of the myocardium. That's the case for an NSTEMI. NSTEMI. That, of course, is not as severe. A STEMI, ST elevated myocardial infarction, involves death of all the way through the myocardial wall. This is sometimes called a mural, M-U-R-A-L, mural myocardial infarction. And you can see the two differences here in the EKG. You don't have significant ST elevation. You might get the T wave inverted in an NSTEMI, but you get this really pronounced ST elevation in the case of a STEMI. So those are your two different types of myocardial infarctions. The most common cause of angina pectoris is coronary artery disease. And in this case, the cardiomyocytes are not getting enough oxygen. And when you have a mismatch between cardiac oxygen demand and cardiac oxygen delivery, you get that pain. So this is a type of chronic ischemic heart disease. The second cause of angina would be the case of hypertrophic cardiomyopathy. In this case, the heart is enlarging, and it's enlarging most often due to chronic high blood pressure. Because the heart is bigger, you have to supply it with more oxygen. The inability to supply it with more oxygen because the heart is responding to increased afterload causes it to enlarge. That's a form of cardiac remodeling. And that can cause angina as well. Coronary artery disease is responsible for up to 50% of all deaths in the US. And yes, that includes COVID-19. So this is common. If you work in healthcare, you will see this. That's pretty global. In fact, in some countries, it's well over 50%. In developing countries, because the age expectancy is lower, People will usually die of things like accidents or infectious disease or something like that. In cases like that, it would be lower, but among the elderly, it's well over 50% in cases like that. In developed countries, it's definitely 50% or thereabouts. All right, so the differences in these two, I put this up just so you can really see. Again, the biggie is the difference is the death of the cardiomyocytes in the case of myocardial infarction and the absence of death in the cardiomyocytes in the case of angina pectoris. Oh, one thing, myocardial infarctions, very often they're due to atherosclerotic plaques that rupture. And so you get a clot, and that clot obstructs the vessel, and you get cardiac ischemia, and you get death of the cardiomyocytes. That clot, however, could have come from someplace else, because clots that form elsewhere can dislodge. And if they form in place, they're called a thrombus. And if they dislodge, now they're called an embolus. And if that embolus then gets lodged in a smaller vessel, now that's called an infarction. And so that myocardial infarction might be the result of a clot that formed elsewhere. If it formed elsewhere, the place where it most likely formed is in the legs. And if you get a patient who's had a crushing injury of the legs, that in fact is one of your biggest worries, is cell debris, clots on the legs, things like that, coming up the large vessels of the legs, getting into the heart, or for that matter, the vessels of the brain, causing an MI or causing a TIA. So that's why crushing injuries of the legs can be so serious for other tissues. All right, so the vessels that feed the cardiomyocytes, this is a result of the coronary circulation route. That coronary circulation route has two main vessels. It has the big vessels on the surface, the conductance vessels. Those are the vessels on the epicardial surface. Those are the ones we went over. The circumflex, the LAD, left anterior descending, the posterior descending, blah, 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 so on and so forth. Then they branch throughout the myocardium, and they, as you can see, you get these plexi, they then feed the endocardium, and then those will then drain into veins, as you can see. So these small vessels are called resistance vessels. Resistance vessels. So you have conductance vessels, those are the big ones. Resistance vessels, those are the little ones. And as you get older, you get more and more of these resistance vessels in the heart. This is the reason why a heart attack in a younger person is much worse than a heart attack in an older person. Because a heart attack in a younger person doesn't have the benefit of this increased collateral circulation. Whereas a heart attack in an older person is not quite as severe because they have more collateral circulation that can work around the blockage. So typically, if you have a heart attack in a younger person, they will usually die from it. When I was in junior high, I got to do a little program where I got to go to Camp Pendleton and be a Marine for 10 days. And I had this big gunny sergeant screaming at me for 10 days. And I was one of the younger ones there, and we had to climb this enormous hill. And one of the guys in our company actually had a heart attack running up that hill. And turns out he had a congenital heart condition that he didn't mention in his medical form. And he went up the hill. He was yelling and screaming at the guys to hurry up and climb the hill faster. And then he was, and he fainted. And so I remember I went back to get him, and my drill sergeant was saying, leave him, you go. because he was going to deal with him. And then I remember asking about him later and then getting screamed at because it wasn't my business. And then it turned out he died. He had a heart attack. And the recruits, the Marine recruits actually take that hill in full gear. We didn't have to do it in full gear. They had to do it in full gear with a 80-pound pack, essentially. And this hill, I mean, it's steep. It's very steep, and it's about half a mile, and you have to run. You can't, walk up it. You have to run up it. So every year, apparently, they'll have people who'll have conditions there. They check you thoroughly in your physical for heart condition, but if that were an older person, essentially, an older person wouldn't have died from that, especially if they got immediate care. Younger people with heart attacks usually die because they don't have that collateral circulation. All right, so the increase in myocardial oxygen demand must be met by increased coronary blood flow. And this is accomplished through autoregulation. Autoregulation. So let's pick on JP over here. Let's say JP decides he's going to go climb the clock tower. And so he straps on his gear and he gets on the clock tower, and the administration comes out and says, Mr. Wiener, please get down. We're calling the police. To which JP says, oh, I'd like to see them get me up here. And he's climbing, he's climbing, he's climbing. As you might have noticed, the clock tower is pretty vertical, and there aren't a lot of places essentially to grab. But JP is working really hard, and he's sweating, and he's huffing and puffing. That's what's going to happen, is that his coronary arteries are going to dilate. And the more harder he works, the more they're going to dilate. And the heart's going to pump faster. That faster pumping of the heart is also going to be accompanied by vasodilation that will deliver more blood and oxygen to the myocardium. Now, when the muscle is contracted, what do you think happens to blood flow through those vessels? You think blood flows through those vessels when it's contracted? No. Blood's going to flow through those vessels during diastole. So systole, you're using it. Diastole, the blood flows. Systole, diastole, systole, diastole. The systole essentially is going to squeeze the blood from the vessels on the inside to the vessels on the outside. During diastole, it will flow. This is one reason why tachycardias can be so damaging to the heart, because they don't give the heart time to oxygenate itself. Now, a vessel that is plugged, like the one over here, that can't deliver as much oxygen. And if that vessel gets 70% plugged, you're going to start having angina. Gotcha? Tachycardias, if they're above certain levels, and if they show certain EKG abnormalities, are typically arrhythmias. Now, with your supraventricular tachycardias, for example, your paroxysmal supraventricular tachycardias, your heart's beating so fast you don't have a P wave. It's just QRS, 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 QRS. Those usually are due to, well, those can be induced by alcohol or excessive amounts of caffeine. In fact, you'll get these in college students who drink a ton and then, oh, I got early morning class, so they coffee, 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 coffee. Essentially, then you take their heart rate and it's 200 beats a minute. That's PSTV. And that is a type of arrhythmia. Yeah. Arrhythmias can be bradycardia, tachycardia, or erratic, essentially. That's highly simplified, of course, but that's kind of a nice way to think of them in general. I tend to think of them as where they originate. Are they ventricular or are they supraventricular? That's how I think of it, but that's me. Okay, so the things that cause the heart to demand more oxygen include, first of all, the rate. Faster heart, it's working harder, it's going to need more oxygen. Also, the force with which the heart contracts. That's going to also chew up oxygen as well. You contract more, you need more ATP. You need more oxygen to generate more ATP. And then the myocardial wall tension. The myocardial wall tension, that's going to determine, so the tonal tension essentially of the heart, that's going to determine oxygen demand as well. What about determinants of oxygen supply? Well, your vessels, can't do much about that. Your vessels are your vessels. You can develop some new vasculature. That takes time and training. That's one thing athletic training will actually do, is increase the amount of vasculature you have in the heart. But the degree of coronary obstruction is often fixed. It'll depend upon the vessel diameter. It'll also depend upon vessel length and the length of the lesion as well. Finally, some people are subject to a pathologic condition called coronary arterial spasm or vasculospasm, vasoconstriction, where the vessel just kind of does this disco thing. It just all of a sudden starts spasming on you. That can cause a very unusual type of angina that is called vasospastic angina. It's also called variant angina, or it's called Prinzmetal, Prinzmetal, Prinzmetal angina. That tends to run in families. So you get people, and usually you'll get it when you lie down at night. You lie down, all of a sudden you get this terrible chest pain, you're at rest. You're not particularly stressed about something. You're trying to go to sleep, and then you get this awful chest pain. Very annoying. So you see here these four types of chest pain. So myocardial infarction, we already talked about. Classical angina is also called stable angina. The production of the pain in the chest is predictable. It's predictable. Then you have unstable angina. The pain is not predictable. Then you have vasospastic angina, which is due to these spasms of the coronary arteries. Okay. Now in your notes, you have a classification of stable angina. And it's classified by class 1, 2, 3, and 4. That's on page 52 of your notes. So classical angina is stable angina. It's caused by atherosclerosis, and it is predictable. And it occurs when your vessels are obstructed equal to or more than 75, 80% of the vessel diameter. So it's classified according to the amount of activity that's required to elicit the pain. So class 1 would be angina with strenuous exercise. You go out and chop a bunch of wood. You go out and shovel your driveway. You go for a long run. You climb 14 flights of stairs and you have chest pain. That would be class 1 angina. It's elicited by strenuous exercise. Class 2 Now it's elicited with moderate exercise. So now you're walking more than 2 blocks at a very brisk pace, and you start to get angina. Or you climb more than 2 flights of stairs and you get angina. That's class 2. With class 3, now you're starting to get angina when you're doing everyday types of activities. So walking 1 to 2 blocks at a normal pace will cause angina. Or climbing 1 or even 2 flights of stairs at a normal pace. And then class 4 would be angina at any level of physical exertion, even at rest. So that is stable angina, stable angina. And it's, you can see here, substernal chest discomfort, characteristic quality and designation, 3 to 5 minutes, so on and so forth, blah, 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 you get the drift. So this is predictable. If a patient has this, they pretty well know what sort of activities will essentially cause them to get pain in their chest. Unstable angina is not predictable. This is usually caused by atherosclerotic plaques that are prone to rupture. So this is more severe than stable angina. The pain will usually persist for longer. It's usually due to progression of atherosclerosis. It's usually due to small ruptures in these plaques. And sometimes you get those in combination with vasospasm. So that's unstable angina. Again, it's not predictable. Then we have Prinzmetals. Prinzmetals. This again, it tends to run in families. People who have a history of, do you guys know what Raynaud's syndrome is? Where you get that tingling, you get your fingers will turn white, and you lose feeling. It'll be red, then it'll turn white. People with lupus sometimes get that. Sometimes it just runs in families. People with Raynaud's syndrome also sometimes get Prinzmetal angina or variant angina. So spontaneous tends to occur at rest. May be involved with atherosclerosis, but not always. Tends to resolve spontaneously. And it tends to run in families. People with vasospastic angina, when you hook them up to an EKG, you might see ST depression, but not always. The etiology of this is really not well understood. Some people think it has to do with the sympathetic nervous system. Other people think it has to do with this stuff called thromboxane A2. Really not clear. With myocardial infarction, the pain is more severe, more intense, and it lasts much longer than in the case of angina. The pain is also accompanied by weakness and sweating, usually also nausea and vomiting, again, because of activation of the sympathetic nervous system. Also anxiety, but it does not subside with the cessation of activity or with nitroglycerin. All right. Any questions about the grading of classes of stable angina before we move on. Allison? You sure would. And that's what that handout here that I gave you, that's what that's meant to show you. All right, so your goal is to relieve symptoms so they can live a normal life, to prevent myocardial infarction, and to prevent death, of course. So those are your treatment goals. So first and foremost, you're going to need them to modify their lifestyle. Atherosclerosis got them there, so they're going to need to start to modify their diet, and they're also going to need to start to introduce physical activity within their limitations. Lipid-lowering agents are usually a must. Beta blockers might be necessary as well, particularly if they've had a heart attack. And then one of your biggest friends are going to be the organic nitrates. And calcium channel blockers maybe, and then maybe also ACE inhibitors as well. So let's talk about the anti-anginal agents. First of all, if they have any sort of unstable angina, or if they have a plaque that looks like it may rupture, one of the first things you'll put them on is a daily aspirin. So the daily aspirin is going to prevent platelets from being able to activate and stick together. So that aspirin will be 81 to 325 mg per day. In fact, if someone is having a heart attack, one of the absolute best things you can do is give them 2 aspirin and have them chew the aspirin. Aspirin has a profoundly positive effect on people having a heart attack. And if you go to the hospital with signs of a heart attack, that's one of the first things they'll do is give you an aspirin. They'll tell you to chew it because it gets absorbed a lot faster that way. So it prevents myocardial infarction. It can prevent a stroke. It's used after CABG, coronary artery bypass. It prevents hemodialysis, shunt clotting. They're just very useful in that regard. You can also use a drug called clopidogrel. Clopidogrel used to go by the trade name Plavix. It's mainly in generic now. This drug's very cheap. You give 75 mg a day orally, and this will also prevent platelets from sticking together, being activated. This drug plays well together with aspirin. The big thing about Plavix, about clopidogrel, you can't take it with a proton pump inhibitor because Plavix, clopidogrel, is a prodrug. And the enzyme that activates it is inhibited by proton pump inhibitors. And usually you take proton pump inhibitors if you're taking aspirin. So that could be an issue. Beta blockers are also useful, and that shouldn't surprise you. Beta blockers lower cardiac rate and cardiac output. Since they lower cardiac output, they're going to lower oxygen demand. Because they lower oxygen demand, they're going to decrease angina. So these are very good drugs for patients who have angina. We've talked about beta these already. You're typically going to want to use a cardioselective beta blocker. The one that you can use for everyday use, you could pop it when you have pain, are your organic nitrates. These are fast acting. These are potent vasodilators. They dilate both veins and arteries. Because they dilate those coronary arteries, they increase delivery of oxygen to the myocardium. They also decrease preload and afterload, so they also decrease myocardial demand. They're useful for all types of angina. You can also use them prophylactically. In other words, you can use them for prevention. Let's say your grandpa wants to go dancing. Say, let's say Jessica marries the love of her life and her grandpa has angina and he wants to dance at her wedding. But he knows if he gets up and dances, he's going to have an angina attack. So what does he do? He pops some nitroglycerin and he dances and he's fine. And he gets through the dance and Jessica floods the place with tears because grandpa danced with her. And it's all very, very charming because he took his nitroglycerin. See, Jessica's ready to cry already. So these are great vasodilators. They reduce preload, they reduce afterload. These come in a lot of different preparations. They come in a sublingual tablet, they come in an oral tablet, they come in a skin ointment, they come in a patch, they come in these buccal strips, they come in lots of different preparations for just about any need. So your two big drugs here are first nitroglycerin and then isosorbide mononitrate. Isosorbide mononitrate has a longer half-life, but takes longer to act. Whereas sublingual nitroglycerin starts working in 3 to 5 minutes. Your isosorbide mononitrate starts working in about an hour. But whereas nitroglycerin works for half an hour, this drug will work for 4 to 6 hours. Your isosorbide dinitrate's not used that much anymore. It's just not that stable. So you're trying to, with these, you're trying to relieve cardiac pain. They can be used for short-term prophylaxis, like dancing at Jessica's wedding, for example. Sublingual nitroglycerin is very good for that. You can use them for long-term prophylaxis. That's what the dermal patches are for, or the oral or the skin ointment is for. You have less frequent dosing. Okay, some side effects. First time you take nitrates, you will get the queen mother of all headaches. And in fact, if you go to the hospital with chest pain, you get an aspirin, an EKG, and nitrates. And then the old joke is then you get some Tylenol for the headache it's going to give you. Because it vasodilates in the brain too. If you're subject to migraines, it may kick off a migraine. So if you're going to get nitrates and you're subject to migraine, if you're giving nitrates to somebody, ask them if they're subject to migraines, because it may kick off a migraine. Stents can prevent it. You'll have to be on medication after you're on the stents to prevent clotting. But stents essentially will undo it. So yeah. They can cause dizziness, especially if you get up. So they cause orthostatic hypotension. So warn your patient to get up slowly. They can cause hypotension. And the nitrates can also cause tolerance. The type of tolerance they cause is a type of tolerance called tachyphylaxis. Tachyphylaxis. What is tachyphylaxis? Tachyphylaxis means that the nitrates are using up a cofactor. that they need in order to execute their function. What nitrates do is so your nitrates degrade to nitric oxide. Nitric oxide activates this enzyme that degrades GTP to cyclic GMP. And this enzyme is called guanylyl cyclase. Cyclic GMP is going to induce relaxation of smooth muscle. So it causes vasodilation. If you use up all your GTP, then the nitrates don't work anymore. You've used up a cofactor necessary for their therapeutic effects. That's an example of tachyphylaxis. So nitrates, if you overuse them, they stop working. And they will start working again. You just need to essentially stop and then get back on, let your body rebuild that amount of GTP in your body, and you'll be fine. So that's an issue with nitrates, is the tolerance issue. All right, we'll pick this up on Friday, and then our quizzes from now on will be online. So we want to have an in-class quiz on Friday. We don't like this.